Hi everyone, I am Dr. Tilini Premadasa, Registrar in Chemical Pathology from Sri Lanka. I am going to present a case report on molybdenum cofactor deficiency with a novel pathogenic variant in the molybdenum cofactor synthase 1. I hope to cover following learning objectives at the end of my presentation. Understand the pathophysiology of molybdenum cofactor deficiency. Identify clinical features, discuss a real-life case presentation with findings, review diagnostic approach and management. Molybdenum cofactor deficiency is a rare autosomal recessive metabolic disorder. It is often fatal in the neonatal period. 4 molybdenum cofactor dependent enzymes are deficient, including sulfite oxidase, xanthine dehydrogenase, aldehyde oxidase, and mitochondrial amidoxine producing component. Among these 4 enzymes, sulfite oxidase and xanthine dehydrogenase play critical roles, resulting in clinical manifestations in molybdenum cofactor deficiency. Key pathogenic mechanism is molybdenum cofactor dependent sulfide oxidase and xanthine dehydrogenase deficiency. Their deficiency disrupts 2 critical pathways: sulfur-containing amino acid metabolism and purine metabolism. As a result, there is an accumulation of toxic metabolites. These metabolites are neurotoxic, leading to oxidative stress, mitochondrial dysfunction, ultimately irreversible brain injury in the neonatal period. The final consequence is severe neurological damage. This diagram illustrates the metabolism of sulfur-containing amino acids and how its disruption leads to molybdenum cofactor deficiency. The pathway starts with methionine, which is converted into homocysteine, then to cysteine, and ultimately to sulfite. Under normal condition, sulfite oxidase converts sulfite into harmless sulfate. In molybdenum cofactor deficiency, sulfite oxidase is deficient, causing sulfite to accumulate. This leads to secondary elevations in thiosulfate, sulfocysteine, and taurine. The buildup of sulfite and sulfocysteine is highly neurotoxic, especially in neonates, resulting in irreversible brain damage. Normally, purine breaks down into hypoxanthine and xanthine, finally to uric acid, via xanthine dehydrogenase, which is molybdenum cofactor dependent enzyme. In molybdenum cofactor deficiency, this enzyme is deficient. So, hypoxanthine and xanthine accumulate while uric acid drops significantly. Low uric acid reduces antioxidant capacity, making neurons more vulnerable to damage. As a result, reactive oxygen species accumulate, contributing to oxidative stress and brain injury in affected infants. Symptoms usually begin shortly after birth, often within the first days to week of life. Closely resemble hypoxic ischemic encephalopathy, but without a history of perinatal insult. Refractory seizures are often the first presenting feature and are typically resistant to conventional anti-epileptic treatments. Irritability and decreased responsiveness may suggest early encephalopathy. Apnea and feeding difficulties reflects both central and peripheral neurological involvement. Infants may show hypotonia, later progress to hypertonia and spasticity, indicating evolving pyramidal tract damage. Ectopia lentis is a classical but variable feature. It may appear later. Opisthotonus can be observed in severe cases. Dysmorphic features may be less frequent and non-specific. Key biochemical abnormalities include very low serum and urine uric acid due to xanthine or dehydrogenase deficiency, leading to accumulation of plasmaxanthine and hypoxanthine. Elevated urinary sulfite or sulfocysteine reflects concurrent deficiency in sulfite oxidase. Shall we move to the index case overview? This is a term baby girl born to second-degree consanguineous parents via elective caesarean section with a normal APGAR score at birth. Notably, there is a significant family history. Her elder sister had spasticity, seizures, developmental delay, and Dandy-Walker malformation. And sadly, she passed away at 8 years of age, raising strong suspicion for an inherited metabolic or genetic disorder. By the second day of life, the baby developed refractory generalized tonic-clonic seizures that did not respond to anticonvulsant therapy. And she also had respiratory distress, recurrent apneic episodes, grunting, poor sucking, and feeding difficulties, all raising red flags for a serious underlying metabolic or neurological disorder. On physical examination, the baby showed signs of spasticity and hypertonia, but no dysmorphic features were noted. EEG was normal and 2D echo revealed a small stem secundum ASD. Biochemical workup shows low serum uric acid and urine uric acid to creatinine ratio, resulting in hypouricosuric hypouricemia. This is due to loss of xanthine dehydrogenase activity. This is supported by massive elevation in plasma hyperxanthine, xanthine, and urine xanthine. Interestingly, urinary S-sulfocysteine is within normal range. Sulfocysteine level was measured on a dry urine spot sent to an overseas laboratory. Since this metabolite is chemically unstable, especially in dried sample, the results may not reflect the true value. The recommended approach is to repeat the test using a fresh liquid urine sample preserved in thymol to prevent degradation and more accurately assess for accumulation. Unfortunately, we couldn't perform it. Neuroimaging findings of molybdenum cofactor deficiency and hypoxic ischemic injury are very similar, showing extensive white matter loss and cystic changes. So most of molybdenum cofactor deficiency are initially misdiagnosed as hypoxic ischemic encephalopathy. In this case, the patient had appearance of global cerebral ischemia affecting the entire basal ganglia, especially in the anterior portions, which is uncommon in hypoxic ischemic encephalopathy. The patient's older sibling had neuroimaging findings consist with Dandy-Walker malformation. Interestingly, Dandy-Walker malformation is rarely associated with molybdenum cofactor deficiency, with a few case reports in the literature. In molybdenum cofactor deficiency, toxic metabolite accumulation, particularly sulfite and S-sulfocysteine, may result in early and severe CNS injury, would potentially mimic Dandy-Walker malformation on neuroimaging. Unfortunately, no biochemical or genetic investigations were performed for the sibling at that time. This leads us to consider, was the sibling also an undiagnosed case of molybdenum cofactor deficiency? A critical reminder of the importance of early metabolic screening, especially in consanguineous families. Genetic testing was performed targeting all exons and flanking intronic regions of MOCS1 and MOCS2 genes. Sanger sequencing confirmed a homozygous variant in the MOCS1 gene. At cDNA position 1807, guanine is replaced by cytosine, resulting in a substitution of alanine with proline at amino acid position 598 and is located in exon 10. This variant has not been previously reported in the literature or in variant database. This homozygous novel variant is consistent with molybdenum cofactor deficiency. Despite supportive care and medical management, the baby's condition continued to deteriorate. Unfortunately, she passed away on the 15th day of life, highlighting the severity and rapid progression of the underlying metabolic disorder. The pathway shown here illustrates how each gene contributes to molybdenum cofactor biosynthesis. MOCS1 catalyzes the first step from guanosine triphosphate to CPMP, cyclic pyraneptine monophosphate. MOCS2 and 3 help convert CPMP to molybdenum. GPHN is involved in the final step of molybdenum cofactor formation. MOCS1 gene is the most common site of mutation, leading to molybdenum cofactor deficiency type A. Mutation in MOCS2 and less frequently MOCS3 result in molybdenum cofactor deficiency type B. GPHN mutations are very rare and cause molybdenum cofactor deficiency type C. Molybdenum cofactor deficiency type A is now treatable with a targeted therapy, which makes major advancement in management. This treatment involves substitution of CPMP using a synthetic analog of fostenopterin. Early initiation of fostenopterin therapy leads to rapid and sustained biochemical improvement and improved neurodevelopment outcome. A few retrospective and prospective studies shown patients with molybdenum cofactor deficiency type A who received fostenopterin are more likely to survive. Some treated patients were able to feed orally and achieve developmental milestones including walking. Fostenopterin was generally well-tolerated drug. Fostenopterin was recently approved by the United States Food and Drug Administration for use in reducing the risk of mortality in pediatric and adult patients with molybdenum cofactor deficiency type A. At the end of my presentation, take-home messages are: early initiation of treatment is absolutely crucial in molybdenum cofactor deficiency, as irreversible neurological damage can occur rapidly in the neonatal period. This underscores the need for a high index of suspicion, especially in neonates presenting with early onset seizures and encephalopathy without clear perinatal insult. Initial biochemical evaluation should start with simple, low-cost and widely available tests such as serum uric acid and urine uric acid to creatinine ratio. If these are suggestive, more advanced metabolic investigation should be pursued: plasmaxanthine and hypoxanthine with urine S-alpha-cysteine. Finally, genetic testing is essential for confirming the diagnosis of molybdenum cofactor deficiency, identifying the specific gene involved, and enabling targeted therapy. Family genetic counseling is also important for future pregnancies. These are my references. I would like to acknowledge Dr. Iresha Jasinghe, consultant chemical pathologist at Lady Ridgeway Hospital, for her expert guidance and supervision. Dr. Dulani Jayawardena, consultant chemical pathologist at National Hospital Kandy, for her support throughout the process. Department of Chemical Pathology at LRH. Synovis Purine Research Laboratory at St. Thomas Hospital, London, for their collaboration and specialized biochemical and genetic analysis. all the postgraduate trainees in chemical pathology, most importantly, the patient and her parents. Thank you very much for your attention. I'd be happy to take a few questions if you have any.